Part series brought to you by the DDA Health Initiative at Georgetown University with support from the DC Developmental Disability Administration. This module focuses on DDA's health and wellness standards. These standards describe the registered nurse's role in promoting access to quality health care for the people they support. The purpose of the health and wellness standards is to help the registered nurse identify appropriate health outcomes leading to the best possible health care and quality of life for people with intellectual and developmental disabilities. The health and wellness standards are not guidelines for specific health conditions, but rather guidelines to assist in the assessment, planning, delivery, and documentation of essential health supports. DDA's expectation for the delivery of health and health support services are clear, and they have three primary areas. One is the focus on preventative health, which is important in today's milieu of healthcare. Second is the expectation for continual assessment for any changes in health. And this continual assessment is certainly supervised by the registered nurse, but may in fact frequently be implemented by non-clinical staff under the direction of the registered nurse. And finally, the registered nurse participates with other members of the support team, including the person with intellectual disability as much as possible, in any care coordination that their health condition requires. This module will review four important tools that are part of the health and wellness standards that help the registered nurse accomplish the goals of achieving preventative health, continual assessment for changes in health, and care coordination. Beginning with the nursing assessment, there will be a separate module that describes all of the components of the nursing assessment and the nursing assessment that leads to the development of a health care management plan. The third tool are the health passports. These are documents that assist in communicating the person's health issues when they interact with other members of the health team, including the primary care physician, dentists, specialists, and hospitals. And then finally, what DDA refers to as Health Form 1, and this is the outline for all of the preventative screening and assessments as required for the person's gender and age. While it is important for the registered nurse to be familiar with the contents of the health and wellness standards, it is also important to recognize that these standards in no way should interfere with the relationship between the person and their primary care provider. Variances for certain immunizations or preventive screening tests may be indicated due to something that is in the best interest for that person. We want to be sure that we respect a person's right to refuse treatment based on informed consent. However, a variance can never be substantiated solely for the convenience of the support team or the healthcare provider. Here are some examples. A young, healthy person may require less frequent physical exams. Even though physical exams are generally recommended on an annual basis, that decision for the frequency of those exams is one that should be decided upon by the primary care provider and the person. Second example is someone who has very severe contractures that may prevent certain testing, for example, a mammogram. A mammogram, the person may not be able to have an accurate mammogram because of their body positioning, or a colonoscopy may be contraindicated because of, again, contractures that may render a typical colonoscopy an unsafe procedure. And finally, if a person has a terminal illness or even advanced age, generally over the age of 75, screening tests are not recommended. But again, that is a personal decision between the patient and doctor. Someone who is 80 years old and in very good health, with a family history of colon cancer, for example, may choose to have a colonoscopy or other form of colorectal cancer screening. The first standard addresses the health passport. This is a document that allows the transmission of essential medical information such as history, current treatment modalities, the person's general level of functioning in a concise way to emergency medical providers, dentists, primary care physicians, and other people in the community. The health passport may be completed by any one member of the support team, not necessarily the registered nurse, but the registered nurse, as part of their quality assurance reviews, needs to ensure that that information is accurate and up to date. The health passport is required for anyone residing in a home licensed as an ICF IDD, or for people enrolled in the home and community-based waiver and receiving residential habilitation, supported living, and host home services. A health passport is recommended for people who live independently or in their family home. However, this cannot be required. And people who do live independently or live in the family home may need assistance from a service coordinator or a day program provider in the completion and maintenance of the health passport. The second standard addresses the coordination of healthcare services. If you are a registered nurse employed by a residential service agency, it is your responsibility to ensure that all healthcare services, including adaptive equipment, are coordinated. This is to be directed by the registered nurse, even if certain aspects of the implementation are the responsibility of other staff members. For example, people who are qualified intellectual and developmental disability professionals, or Qs, sometimes referred to as Qs, may do a lot of this work in terms of assuring transportation, communication with a day program, communication with medical equipment providers, but the registered nurse does need to review this and make sure that all steps are occurring timely, that all medical information is available and up to date, and that any type of assessment related to nursing care is part of the information package. When the registered nurse delegates the coordination of care to another member of the support team, the RN must be sure that the staff has the capacity to perform all necessary tasks, and this includes strong written and oral communication, and the delegating RN must provide periodic supervision of these tasks. The third standard addresses DDA's expectations for preventative health care. The expectations are documented and outlined on Health Form 1, and they are based on the recommendations of the U.S. Preventative Screening Task Force. These guidelines are generally geared to the person's age and gender. A couple of points to make about Health Form 1. First, in looking at the section on colorectal cancer screening, one of those screens are required, not all three. Other screening may be the responsibility of the registered nurse, or the registered nurse could collaborate with other members of the team, for example, a psychologist. When we look at the section on mental and behavioral health, there should be an annual screen for depression. It's recommended that the Glasgow screen is utilized because that is a screen that was developed for use with people with intellectual disabilities. And in the dementia screening, there is a screen recommended by the Task Force on Dementia Screening, again, a screening questionnaire that was developed specifically for people with intellectual disabilities. There is a section that makes recommendations for people with Down syndrome. Immunizations need to be reviewed, although the immunizations are part of the health passport. You should be using the immunization documents as provided by the Centers for Disease Control and Prevention. And then for the person's individual needs, there may be other screenings that are indicated based on the person's current history or the family history. At the conclusion of Health Form 1, there is a note that gives some language and recommendations that if the primary care provider is recommending a variance from these preventative screening guidelines, this needs to be documented in the medical record and available for any monitors who want to see verification of that recommended variance. Standard 4 describes the processes that should be implemented if a person is experiencing declining health. The registered nurse and other members of the support team are responsible for timely and adequate medical evaluation to try to identify the etiology of the problem. There should be documentation of referrals to medical consultants and specialists. Any recommendations that come from those referrals need to be acted upon in a timely manner. If the primary care provider and the support team decide to not take the recommendation of the specialist, there needs to be adequate documentation as to why that recommendation is not going to be followed and what alternatives the team is recommending. The findings from the primary care provider and the medical specialist needs to be integrated into a comprehensive plan of care, and either the primary care physician or the registered nurse can do that via a progress note that documents what the team is considering, what are some of the risk benefits, what are some of the alternatives, what are the decisions of the person with a disability or their healthcare decision makers. DDA offers the consultation services of Dr. Kim Bullock for anyone with complex health needs. This consultation is offered as a support to the team to help them in the management of people with very complex needs. And you should consider a referral under the following conditions. Someone who's been admitted from the emergency department directly to intensive care services, someone who is being admitted for hospice care or being considered for hospice care, sometimes medical specialists may present conflicting recommendations, and in those instances, if two specialists have made conflicting recommendations or the primary care physician is not willing to go along with some of the recommendations, it would be beneficial to make a referral to Dr. Bullock to facilitate good communication among the medical professionals. Dr. Bullock should also be consulted if a person who is in the hospital has had a change in status and requires a transfer to a critical care unit. Anyone who's been hospitalized with a length of stay of over 2 weeks, and someone who has had a decline in their functioning for which no cause has been determined. And finally, a consultation with Dr. Bullock is appropriate if a person has just received a diagnosis of cancer, or if the decline in function is related to a major organ system, such as the cardiovascular system, because that does usually indicate multiple other systems that will be affected and their functioning in their activities of daily living. and the person who's experienced a weight loss of more than 5% of their body weight that has been unintentional. This is the contact information for referrals to Dr. Bullock. The fifth standard addresses the development of the healthcare management plan. There is a separate module on the healthcare management plan development and the nursing assessment, but briefly here, the healthcare management plan represents both a comprehensive and individualized document that summarizes a person's health needs, the expected outcomes, and the interventions required to maintain optimal health. At a minimum, it is developed annually and then is reviewed and updated at least quarterly by the registered nurse. The healthcare management plan must be reviewed at least quarterly by the registered nurse. Updates to the plan, modifications to the plan, are required if the person has a new diagnosis, whether it's a medical diagnosis or nursing diagnosis, if there's any change in their health status that will require additional intervention by other members of the team. So for example, someone comes back from the hospital, they have a surgical wound, they have to be assessed for pain, they have to be assessed for appetite changes. That would indicate a change to the healthcare management plan. And any type of nursing assessment that establishes the need for any kind of additions or modifications. All complete documentation is expected within 7 days of the change in condition. Standard 6 addresses medical consent. Consent is required from the person or anyone who is supporting the person in healthcare decision making, including guardians, around all of their medical treatment, any proposed changes to the medical treatment, and that includes changes to medications. Let's take a look at the term capacity. The capacity to give medical consent means that the person has the mental ability to understand the nature and implications of a decision, including understanding that there in fact is a decision to be made. A person with capacity also understands that the information being presented includes alternatives. So that it is, you can either have treatment A or treatment B. You could have treatment A or choose not to have any treatment at all. What are the alternatives, and understanding the weight of those alternatives. And finally, the person with capacity has the ability to communicate their decision and thus give consent that is informed. If someone is unable to give consent, they can have a substitute decision maker. A substitute decision maker is anyone authorized by the statute that is followed in the District of Columbia to make decisions on behalf of another person for medical treatment. And there is actually a hierarchy of those people who can be substitute decision makers, starting with family members, but may also include longtime personal friends. The exception would be it cannot be someone who is in a paid capacity to render services. Other substitute healthcare decision makers are those guardians that are appointed by a court, either as a permanent limited guardian for healthcare decision, or even a guardian that is appointed on a temporary basis. For example, a person, because of a catastrophic health situation, could be temporarily incapacitated to make decisions, but they are expected to be able to regain their capacity. In that instance, it is appropriate to appoint a temporary emergency guardian for healthcare decisions. Unless it is an emergency situation, the healthcare decision maker or guardian should be notified of medical appointments in advance. In discussion with the healthcare decision maker or guardian, they may request that routine appointments be kept and they only are informed of the outcomes. However, if that is the situation that the guardian or healthcare decision requests, that should be put in writing so that the expectations of notification are clear. Whenever possible, any type of medical treatment, medication, psychotropic medications should be explained to the person receiving those treatments in a way that is easy for them to understand, even if they are not the ultimate person to provide consent. Respect for the person would dictate that they are included in that decision making and that they are informed about what is happening to them. The guardian or healthcare decision maker must give consent in advance for any medication that has the potential for any type of significant, potentially dangerous side effects or anything that may be controversial. Also, any risks associated with psychiatric medications need to be outlined by the prescribing physician using the Universal Psychotropic Medication Review Form. Because medications include side effects and some side effects that can be potentially life-threatening, support staff need to be aware of possible side effects. The most important thing for direct support professionals is to understand and report changes in someone's condition. They are not expected to synthesize the information or analyze the information or make a determination if the observations are in fact a medication side effect. But they do need to be sure that they clearly report as soon as possible their observations to the nurse. The service coordinator or RN also needs to inform a guardian or healthcare decision maker when any tests are ordered. For people who do have the capacity to consent for themselves, you need to make sure that any explanations are clear and easily understandable. This may include repeated explanations, having someone who they trust to be present when the explanation is given, or using visual input to assist the person in understanding the information presented. The person should also then be able to repeat the key concepts so that you can determine, in fact, if the consent is informed. Standard 7 refers to the reporting of critical incidents. DDA has a set of policies and procedures related to incident management and enforcement, and their website should be consulted for detailed explanations of those policies. But there are two types of reportable incidents. There are those incidents that are considered reportable. This includes some type of emergency room or urgent care visit, fire, inappropriate use of restraints, medication errors, vehicle accidents, etc. And there are those incidents that are categorized as serious reportable incidents. Serious reportable incidents, or SRIs, include but aren't limited to abuse, death, exploitation, inappropriate use of restraints that results in injury, a missing person, neglect, repeated emergency use of restrictive controls, and a serious medication error, injury, suicide attempt, and unplanned or emergency inpatient hospitalizations. Again, please refer to the DDS Incident Management and Enforcement Policy and Procedures. Standard 8 outlines the nurse's responsibilities as it relates to behavior support plans. Positive behavioral support is a very integrated aspect of the healthcare delivery for people with intellectual and developmental disabilities, both because sometimes untoward behaviors are exhibited in response to pain or a serious illness, or the failure to provide positive behavioral supports that are effective could lead to injury. This is an area where most basic preparation of registered nurses is quite limited, and it is strongly suggested that the registered nurse who continues working in the field of developmental disabilities seeks out additional training and education so that they can truly be part of the full support team in the coordination of behavioral support plans. It is important to remember that DDA requires a behavioral support plan to be developed under the following circumstances. 1, the person may be exhibiting behaviors that pose a threat either to themselves or others. 2nd, if one or more psychotropic medications are prescribed for behavioral support. The team can request an exemption from a behavioral support plan if only one psychotropic medication is prescribed. However, that request for an exemption must be submitted to DDA. The third example would be if any restrictive controls are recommended. Restrictive controls in and of themselves are not bad. Sometimes restrictive controls are needed for the health and safety of the person. They may be needed to help shape behavior that is more positive and allows the person to be a full member of their community. However, those restrictive controls must be part of a behavior support plan that is developed by a qualified person and is reviewed by DDA's Restrictive Control Committee. And finally, if the person requires sedation prior to a medical or dental appointment, that must also be part of a behavioral support plan. A behavioral support plan is optional if the behaviors for which the person requires support are of the nature that may interfere with their learning goals, may interfere with community integration or other personal outcomes. So while these are serious issues that need to be addressed through the types of services and supports the person receives, a formalized behavioral support plan is not necessary. A second example where a behavioral support plan may be developed but is not required is if the behavior is a form of communication or some type of alternative form. So people with, for example, autism engage in sometimes hand flapping, body rocking. People with visual impairments also do the same thing. So while you may want to try to substitute some other activities to see if that behavior can be reduced, a behavioral support plan is not necessary. And in fact, you may want to consider whether you even want to address some of those types of behaviors in the first place. There are 3 important tenets to remember when developing behavioral support plans. First of all, the development of a plan is a collaborative, person-centered planning process. So the person whose behavior you desire to impact needs to be involved to the extent possible. You want to have a full participation of everyone in the support team, include family members if the person spends a considerable amount of time with their family. And this is another reason why nurses who work on behalf of people with developmental disabilities really do need to get some additional training in behavioral support planning. However, the actual plan that is formally developed and the person who is the signatory on that plan can only be either a licensed clinical psychologist, a clinical social worker, a licensed professional counselor, or a behavior management specialist. And third, a functional assessment of behavior must precede the development of the plan. Again, for more information about functional behavioral assessments, there are a wide variety of professional articles. There is a lot of information on the internet that can describe to you what a functional assessment of behavior includes. Standard 9 addresses the use of restrictive procedures. Remember that the first choice is always using strategies and supports that are proactive and least restrictive and that help the person with an intellectual disability remain engaged within their community environment. However, there are times when restrictive controls may need to be considered. Please go to Standard 9 in the Health and Wellness Standards to read a more descriptive account of restrictive procedures and when it is appropriate for them to be considered. But do remember that all provider staff must be trained on each person's behavioral support plan with whom they work. And this is something that, because nurses interact with the staff much more frequently than the clinical psychologist or other behavioral support provider, it is something that could be under the purview of the registered nurse to observe people implementing the behavior support plan. Are they implementing the plan competently? And to determine if additional training may be required. The registered nurse would not necessarily have to do that training, but would again collaborate, communicate with other members of the team, with the QDPP, with the clinical psychologist, to let them know that they may need to perform some additional training. All community provider agencies are to have written policy for restrictive behaviors in accordance with DDS's policy, and there needs to be evidence that those policies are in fact implemented by all staff. Any mechanical restraint must be authorized in writing by a licensed healthcare practitioner, and the order must include the following elements. 1, the duration of use. 2nd, the circumstances under which the restraint is to be used. And 3rd, the frequency of staff monitoring of the person while the restraint is in use. Standard 10 discusses the universal precautions and bloodborne pathogen training. This standard does not replace OSHA training, but it does give the OSHA definition and outlines the provider responsibilities for which the registered nurse is often involved. It discusses the frequency of staff training and the requirements for documentation, the service provider's responsibility to offer the hepatitis B vaccine to employees, what to do in the immediate post-exposure evaluation for employees, and the responsibility to provide your personnel with protective equipment when indicated. For consultation regarding specific infection control management techniques, please contact the medical director of the DDA Health Initiative, who frequently consults with infectious disease specialists in the community to answer questions about the need for infection control in the home setting. Standard 11 addresses the management of 4 frequently seen infections in community residences. The information given is brief, but can be used to begin the nurse's assessment of any environmental modifications that need to be made based on the particular diagnosed infection. This information can also be used in training for staff. Additional information and updated information can always be found on the Centers for Disease Control website. Again, if individual consultation is required to help determine what environmental modifications may be necessary, please contact the medical director of the DDA Health Initiative for consultation. Standard 12 discusses the annual physical exam and what constitutes the comprehensive delivery of medical services. The type of physical assessment that is indicated for each person is dependent on the person's age, their gender, and their general physical health. However, you do want a summary of that annual physical assessment and any recommendations to come back to you in writing so that it can be included in the person's medical record. Standard 12 also discusses the importance of communication between the primary care provider and any specialty consultants, and the importance of making sure that information goes to the specialist about why the primary care provider is requesting a specialty consult in the first place, any background information that may include history, recent laboratory tests, any behavioral data. And then once the specialist has made their recommendations, those recommendations need to be reviewed by the primary care provider so that they can determine if in fact the recommendations will be carried forward, if any modifications are needed, or if a second opinion is in the person's best interest. Today, with the widespread use of the electronic medical record, the documentation of the annual physical is likely to be on a preset format from the primary care provider. However, the documentation that you receive from the annual physical exam or the annual medical assessment should be reviewed to be sure that the following elements are present. The physician's name, signature, and date. The date is very important. The physician should present a complete medical problems list. There should be a complete body systems review and make sure that there is no erroneous information, such as a man having checked off that they have female genitalia or anything like that. There should be a complete list of the prescribed medication, including any over-the-counter medication that the physician is suggesting for use, and a list of any kind of laboratory, diagnostic, or preventative screening test or any other recommendations that are being made as part of the annual physical assessment. The registered nurse and other members of the support team can make a valuable contribution in preparing the person for a successful annual physical exam. First of all, in making the appointment, make sure that there is sufficient time allotted. Some people may require an extended appointment from the physician, or they may require the physical assessment to be done in 2 separate appointments. Be sure that you are working with the primary care physician and their office staff to notify the office in advance if you anticipate any needs around time allotted for the exam. Second, you know the person best. Consider their need for behavioral supports. Are they going to need a behavioral support plan for sedation? Do you want to make sure that they are going to the appointment with a staff member who they trust and who they're very familiar with? These are all behavioral supports, making sure that the time leading up to the appointment is not rushed so that the person is agitated. The registered nurse needs to anticipate the upcoming appointment and make sure that the health passport that is sent on the appointment is updated. Also, the registered nurse should review Health Form 1 and anticipate if there are any screening tests that may be indicated. You may want to alert the physician or the health practitioner that certain exams may be due and ask if the physician or health practitioner intends to order those exams, or are they going to document a justification for a variance. Also take a look at the immunization schedule and advise the health practitioner if there are any immunizations that may be due. And finally, send along a copy of any recent specialty consults or any reports from the emergency department. Standard 13 discusses the requirements and expectations for dental care. At least 2 dental exams are expected annually for preventive care when people have their own teeth, including radiographs up to 2 times a year, as indicated by the dentist. And scaling and prophylaxis can be done including a minimum of 3 visits annually for a person with periodontal disease, although the dentists do require prior authorization from the Department of Healthcare Finance. For a person who is edentulous, 1 or 2 soft tissue evaluations is recommended annually, although that does not have to be performed by a dentist. It can be performed by the primary care provider. It can be performed by the registered nurse as part of the annual and semi-annual physical assessment. Of course, they may go to the dentist if desired. If someone has dentures, they need to be evaluated for comfort and function, and to be sure that any ill-fitting dentures are not causing damage to the soft tissue, or that the person is not able to use them and therefore at risk of not eating the proper fiber content in their diet because the dentures are not functioning. If someone does require general anesthesia for exams, the general anesthesia is not recommended more frequently than every 3 years. In this case, then, the person is going to be receiving less frequent exams, and so dental hygiene becomes extremely important for the maintenance of good oral care. Standard 14 addresses hearing screening and the use of hearing aids. It is the responsibility of the interdisciplinary team to determine what are the appropriate levels of screening, taking into consideration how the person uses sound in day-to-day communication. So there are times where, again, because we are talking about a screening, not an assessment, that the screening can consist of the person's ability to hear sound, that they do not see where the source of that sound is coming from, or observations in their daily living environment. Do you have to repeat instructions to them? Are they having problems completing oral requests that are made orally to them because you're now suspicious of a hearing problem? If a change in hearing status is noted, the first thing the registered nurse should do is to rule out, is there a wax impaction or is there an infection present using an otoscope. You certainly can consult with the speech-language pathologist or even the psychologist on the team to, again, help determine how they assess the person's need for hearing and communication. And then certainly if hearing aids are indicated, some individuals may require ongoing and intense planning to help them adjust to the presence of the hearing aid and how to use it for optimum functioning. Standard 15 addresses vision screening and an eye health care plan. So screening is recommended annually for adults 19 years and older. And this screening, because again it is a screening, not an assessment, can be conducted by the registered nurse as part of the assessment. However, sometime between the age of 19 and 39 years, all adults should have glaucoma screening that is performed by an optometrist. It's an important part of the family history to determine if any relatives do experience glaucoma. Once the person is 40 to 64 years of age, the glaucoma screening is indicated every 2 to 4 years, and 65 years and over every 1 to 2 years. So again, you see, even within the range that is recommended in screening, there is some opportunity to have more frequent screenings or less frequent screenings. And clearly, anyone for whom a vision problem is suspected would be brought in for an evaluation by an optometrist or ophthalmologist as soon as possible. DDA Standard 16 regarding immunizations discusses the provider's responsibility of maintaining a record of adult immunizations. Adult immunizations have become a very important part of routine health care, and you can follow the link to the Center for Disease Control and Prevention adult immunization schedule. This schedule should be kept in the health record as part of the health passport so that when the person goes to an emergency department for a visit or to their primary care provider, it is easily ascertained which vaccines may be required and their full vaccine status. Standard 17 is in two parts. First is the medication prescription, and second, the administration of medications. The standard related to medication prescription includes a detailed list on what constitutes medication orders, their renewal times, what to do when any medication dosages are changed, and the acceptance of medication orders over the telephone. The standard also addresses the use of as-needed medications and the importance of the prescribing health practitioner, including specific written parameters. All of those parameters are outlined in Standard 17. The registered nurse needs to check all medications and dosages for accuracy at the time that they are received from the pharmacy or at the time of purchase. And the registered nurse also needs to be sure that the medical record includes specific information in the file about the medications, any instructions, the name and strength of the medication, etc. Again, these details are all outlined in Standard 17. And finally, the current list of medications need to also include the diagnoses and or symptoms for which the medications are prescribed. And that needs to be documented on both the medication administration record and the health passport. Next, Standard 17 discusses the requirements when medication is administered for someone. It discusses the requirements of documentation on the medication administration record. Again, this is for people who are not self-medicating. It also outlines the documentation requirements in the event of a medication error and how to document the administration of as-needed medications. Under the TME regulations, as-needed medications require an assessment by a licensed nurse or physician prior to the initiation of administration by the TME. Standard 17 also addresses the importance of medication storage, proper medication storage in locked cabinets or refrigerator according to the nature of the medication. And also the requirement for a supervisory registered nurse to review the practitioner's orders against the medication administration record during periodic reviews for all people receiving those medications, at least on a monthly basis. The registered nurse is encouraged to assess people for their possible participation in self-medication education, and in fact, in an ICF setting, it is required annually. Standard 17 delineates the steps to take in the assessment of self-administration for medication, and a link is provided to a tool that can be used in the self-medication assessment. It is important to note that the competency of a person to continue administering their medications does need to be reviewed periodically depending on the person's ability to take their medication, and also taking into consideration the impact that a health condition can cause. So someone who had been very healthy and self-administering the medication, if they have a serious flu, or if they have been hospitalized, or if they have a change in their health condition, their ability to self-medicate may need to be reevaluated, and some additional supports may need to be put in place. And that includes any exacerbations in a person's mental illness. Standard 18 is a comprehensive review on the use of psychotropic medications. These medications must always be part of an overall treatment strategy. They are never to be the only treatment strategy to address a person's mental illness or behavioral health problems. The team must work to always determine the minimal effective dose. This does not necessarily mean that the medication must be reduced or that there is a requirement for a medication to be eliminated, but the team led by the psychiatrist needs to consider any type of minimal dose, and they need to weigh the risk and benefit of continuing the medication with potential side effects in light of the person's ability to address their mental illness and to be able to live the lives they want to lead. Psychotropic medications can only be administered to people who have undergone a formal psychiatric assessment and have received the assignment of an Axis I diagnosis by a board-certified psychiatrist. Tardive dyskinesia screening is outlined in Standard 8, and that is required every 6 months, and it is required for any medication that can cause the side effect of tardive dyskinesia. Overall, the support team needs to review the use of a psychotropic medication to determine its effectiveness, to look at other factors that may be causing some behavioral problems at least every 90 days, certainly more frequently if indicated. And the psychotropic medications must be renewed by the physician or nurse practitioner at least every 30 days. I encourage you to follow the link to the supervisor's checklist, because this checklist is actually a compilation of a comprehensive consensus guideline article that has not been duplicated from the time it was published, that helps the practitioner consider other factors other than medication in addressing mental health disorders. Standard 19 is a brief review of what constitutes appropriate psychiatric services. Psychiatric services must be delivered by a licensed psychiatrist who provides assessment, diagnosis, and treatment. Support teams need to ensure that they have a uniform way of documenting their review of a person's health conditions, their review of behavioral data, and present it to the prescribing psychiatrist. DDA recommends adopting the use of the Universal Psychotropic Review Form that can be found by going to this link. It is also found on the DDA website and the DDA Health Initiative website. This 3-part form is intended to be completed, parts 1 and 2, by members of the support team, delivering that information to the prescribing psychiatrist for the psychiatrist's review. The psychiatrist then completes the 3rd part of the review form by acknowledging and documenting that they have reviewed that information, and it includes documentation of some concepts of the minimal effective dose consideration, the consideration of any potential side effects, and then gives a place for recommendations, including any changes in medication. Standard 20 addresses the use of therapeutic services, including occupational and physical therapy, speech-language therapy services, and nutrition services. All of these services require a physician's order, which needs to be maintained in the health record. Once the assessments have been completed, written documentation in the form of reports, assessment, any visitation notes, and progress notes are to be maintained in the health record. It's important to note that the registered nurse is responsible for being aware of the content of that information. The registered nurse is responsible for contacting any of those therapists if their assessment differs from the assessment that the registered nurse is receiving, so that the information can be coordinated and the right approach can be determined. The registered nurse is advised to read all reports and assessments, at least as part of the annual nursing assessment, and certainly periodically as those reports come in, to be sure that the healthcare management plan is updated and that the nurse is fully aware of the impact of any of the other therapist recommendations on the nursing care provided. Standard 21 addresses the stages of change model. For people whose health would benefit from a lifestyle change, for example, quitting smoking, losing weight, or reducing or eliminating alcohol intake, support teams need to be familiar with the stages of change. The stages of change model puts an emphasis on the person as a decision maker in the type of modifications they are willing and able to make at the current time. We want to get away from emphasizing what people refuse to do, which focuses on their failure and can become quite discouraging, from focusing instead on the benefits to lifestyle changes. But again, recognizing the very important part of accurately assessing where the person is on the stages of change continuum. So Standard 1 discusses these various stages, starting with pre-contemplation. So at pre-contemplation, if we use weight loss as an example, the person may be 50 pounds overweight, and you discuss that with the person as part of your nursing assessment to try to determine, is this something important to the person? We know that a 50-pound weight loss would be important for the person, but we need to assess, is this important to the person? If through motivational interviewing you determine that this person has absolutely no interest in modifying the diet, you would then appropriately assess that this person is at a pre-contemplation stage. And then your next steps might be to determine a time in the future when you will review their stage of change. You may want to go back every quarter, or you might want to go back at the 6-month mark to see if the person has made any changes. You might want to have some information around the house about the benefits of weight loss, or you might praise someone who has been successful in their weight loss in front of the person. But you do have to respect, if the person is really at the stage where they are not considering any change, the best course of action is to back off at that time. The second stage is contemplative. In this stage, the person has some ambivalence. They know that they need to lose the weight. They can think about how nice they might look in their clothes once they fit better, or to be able to buy new clothes that are smaller, but they're quite ambivalent. They may be really just having a hard time getting the willpower together to make that change. In this stage, you would want to perhaps get back with the person within a shorter time frame. You might want to get back with the person in a month, or you might want to suggest that the person have a consultation with a nutritionist, or maybe attend a Weight Watchers class. The third stage is the preparation. Now the person is really considering experimenting with some small changes. This is the time to make sure that there are really robust supports around the person. Make sure that everybody on the team is on board. So for example, someone has decided they are going to really start making some changes to their diet, and the first day in this period of diet modification, there's some kind of a big party at the person's home, make sure that there are healthy snack choices available. In the action stage, the person is actually making some success. Again, make sure that everybody on the team is on board and that that person is being praised for even the smallest successes. The next stage is called maintenance and relapse prevention. This is the time where you may be close to your weight goal, and now you really have to incorporate this new behavior into lifestyle. This is not a diet. This is not something that you do for a set amount of time, but it is something that is done throughout your lifetime to maintain your goal of weight maintenance at your ideal body weight. You have to make sure that any relapses don't result in just abandonment of the whole process altogether. Help to counsel the person that relapses are likely to occur. You can even counsel the person if they can understand that sometimes when that happens, the person feels really bad about themselves, they feel discouraged, they want to throw in the towel, and help them expect that these feelings are natural, but it doesn't mean that you have to go back to some of your former eating habits. Again, all of these interventions have to be matched to the person's readiness for change. The health and wellness standards provide links to the full article on stages of change and even some information about how to conduct successful techniques for conducting motivational interviews. Standard 22 addresses seizure disorders and protocols. Seizure disorders or epilepsy is very common comorbid medical condition in people with developmental disabilities, and it's important that all of the staff is prepared to support someone who does have epilepsy and who will require routine visits and consultations with a neurologist. Be sure that when attending neurology consults, that a record of seizures from the time of the last appointment accompany the person so that the neurologist can gauge the effectiveness of the current medication regimen. Be sure that the health passport includes all the medications and diagnoses of epilepsy and that they are updated as medication changes occur. Be sure also that the attending neurologist receives any data related to recent behavioral changes, because the behavioral changes may actually indicate some symptomatology of a certain type of seizure disorder. Seizure records must be maintained in the health record, and be sure that the staff knows how to accurately complete the seizure record. There's a wonderful online seizure record called Seizure Tracker, and the link to this is included, and I suggest that you take a look at it and maybe compare the seizure tracker to your current way of monitoring seizures. Standard 23 addresses the use of adaptive equipment. Adaptive equipment is very important for the independence of people with disabilities and comes in many, many forms. The need for adaptive equipment actually must be evaluated on a continual basis. It is not the sole purview of any one therapist, but in fact everyone on the team should have an obligation of being familiar with current adaptive equipment possibilities, how they could benefit people, and to think about how adaptive equipment may be able to promote the independence of the person under consideration. All recommendations by therapists, whether they make a recommendation for the use of adaptive equipment or perhaps defer the use of a piece of adaptive equipment, should be reviewed by the registered nurse and considered and determine if you agree with that, or perhaps you have some additional information that may alter the therapist's recommendation. It's important that there is regular monitoring for the proper fit, usage, and safety of any piece of equipment. Again, because the registered nurse is frequently in contact with the person using the adaptive equipment, the registered nurse has the opportunity to observe the use of the adaptive equipment, to observe the familiarity of the direct support professional in using the equipment. Maintenance is extremely important, particularly for things like wheelchairs that have moving parts. They must be maintained as directed by the manufacturer. They need to be kept clean, they need to be kept oiled in some instances, so to reduce the frequency of breakdown. DDA has prepared an adaptive equipment maintenance protocol, and I suggest that as the registered nurse, you become familiar with its contents. Standard 24 addresses end-of-life planning. This is not a single event or an event that needs to be postponed at a point in someone's life when they are in the midst of a critical illness. It really is an ongoing series of conversations and choices, something that should be reviewed annually with the person and any healthcare decision maker. And sometimes it's simply introduced to the person, the concept is introduced, and perhaps some material is offered. In the appendix of the Health and Wellness Standards is a document called Thinking Ahead that can provide a good foundation for beginning some of that discussion. If any additional consultation is desired related to end-of-life planning, you can contact the DDA Health Initiative for some additional information, training, and support. It is important to document any end-of-life decision-making activities, which would include discussions with the person, their support team, healthcare decision makers, family members, any sharing of resources, whether it is a referral to palliative care team, referral to a hospice, or the suggestion of seeking out counsel from the clergy. Any specific end-of-life plans should be included in the medical record, including if the person has the capacity to execute an advance directive. That shouldn't just be filed in the medical record, but everyone in the team needs to know that it is there and that it needs to accompany the person on any emergency visits. The use of alternative and complementary therapies is becoming increasingly more common, and Standard 25 addresses how to use these in an optimal way. They must have a written order from the primary care physician, and it is important to discuss not only with the primary care physician but any other specialist if there are other alternative and complementary therapies in use. This should be documented in the health record and included as part of treatment strategies documented on the health passport. The registered nurse should follow up and document the outcomes, just as we document on the health care plan expected outcomes. What is the expected outcome in using the alternative or complementary therapy to help examine and assess its efficacy?